This is our second attempt to get this afternoon event started. We did anticipate a bit of time. Last time it took 1.5 hours for people to come back from lunch. And so we pretended there was going to be a 30-minute case presentation on the case that we're going to be discussing. Today we have a really exciting debate with some powerful debaters. As I mentioned earlier, last year we had a debate about thrombolysis or primary PCI, and David Kettles was roundly the victor, according to most people that I polled. Ahmed Suleiman has come back for a double or nothing bout, and this time, interestingly, David Kettles will be in the corner fighting for PCI, which is a slight change in his previous approach. To get us started, Bernard Gersh, who hasn't yet come to the fore yet, so I'll introduce him appropriately. If you can all settle down, can we close the doors at the back, please? Can we close the doors at the back, please? Or just ask for a bit of silence. So I'm going to introduce Dr. Bernard Gersh, who is from the Mayo Clinic, probably the most distinguished cardiologist in our group, and we have a lot of very distinguished cardiologists. He has won the gold medal recently from the European Society of Cardiology. He won the Distinguished Scientist Award from the American Heart Association, and has more than 1,000 publications, which is very difficult to have on the course director's website his name next to yours, because his bio is several pages long and yours is just a small paragraph. And he's going to lead us through the proceedings and tell us about the rules of engagement for today's debate.
Thank you very much. So the principles of the debate are really as follows. I'm going to just show 4 slides to set the ground rules as Mo suggested. Probably the most distinguished debating society in the world is that at Oxford University, one of my alma maters, where they state that a debate should be 20% fact, 10% humor, and 70% eloquence and style. The medical debate is being changed. 20% facts, 10% humor, 0 flexibility, and character assassination. So, Ahmed and Dave Kettles, I ask you please to follow the Oxford School. Secondly, there are a lot of young people in the audience here. Viewer discretion is advised. The following debate may contain strong language and even violence. I think what you have to do is learn from the English, who can be extremely unpleasant with a smile on their face, and you don't even know you're being nailed. And this is, as Prime Minister Disraeli said of Gladstone, I do not think him stupid. It is just that he believes in so many things that are wrong, which I think is sums it up. And then finally, gentlemen, what we would like to avoid is this. This is a fatality following a controversy between 2 medical men. In Germany, disagreement over conduct of an operation led to a duel between 2 surgeons. One of them died of a fatal penetrating wound of the thorax. And then the comment was, happily in this article, the vast majority of medical men of all nationalities are the possession of well-balanced minds and altogether exceptional occurrence. And you'll see that this was, I didn't show it here, but it was published in the JAMA 1897. So times have changed, and hopefully we'll have a much more peaceful ending to the debate today. And we'll start with the case report.
Dr. Yacoub.
Dr. Yacoub? Oh.
Good afternoon, everybody. Welcome back after lunch. Good afternoon. I'm presenting this case, and I think this is one of the most common cases we encounter all over Africa. No conflict of interest. It's quite a gentle young man. He's 42 years old. He has no background medical history of note. He's not diabetic, no hypertensive. But as many young guy in Africa, is heavy smoker for a long time. This time experienced severe central chest pain that is quite consistent with acute coronary syndrome and probably a pain of myocardial infarction. With background of milder form of chest pain over the last 3 days. So 3 days I was on and off chest pain. Then he had this severe form of chest pain. He was seen in a very remote hospital, diagnosed as acute myocardial infarction, loaded with aspirin 300 milligram crush, along with sublingual nitrate, but no clopidogrel, no heparin, and referred just for further treatment. Assessment initially looks stable, young gentleman. When reviewing his history, the chest pain was actually 27 hours ago, so more than 24 hours. At that moment, there was no clear chest pain, but some discomfort. Blood pressure was stable, pulse was okay, apart from tachycardia, and hopefully there was no clear sign of heart failure and no cardiac murmur. This is ECG, if clear to you.
Not very clear.
Not very clear.
Tell us what it shows.
It is quite clear.
This side.
It does show ST elevation with QF in anterior lead from V2 to V5 or V6. With ST elevation in one and AVL as well. Cardiac troponin came to be very high, that is 6.4. That is more than 200 reference limit, upper reference limits, quite massive in fact. Blood count, just need to feel leukocytosis, kidney function were normal. And echo showed akinetic anterior wall with EF of 30 to 35, with no septal defect or LV clot. So the next step, then we discuss his condition, his and his family. We did explain that is there a lot of delay anyway, and we agreed to go for early and cut. This is right radial approach angiogram, done on the same day after arrival to ER. Right coronary artery was quite normal, as you see. Left system, the left circumference is quite normal. There was occlusion of LAD, and in the cranial view is quite clear that LAD is totally occluded. And of course, you can see some thrombotic occlusion with timid flow distally. So now this is a case, this is angio. What next? How we could approach this case? You will see two distinguished guys, cardiologists, are going to debate which approach.
Thank you. Okay, first is Mohammed Suleiman is going to state that he's going to argue the case for a conservative approach, and then David Kettle will argue the case for PCR.
So before I start, there's just a bit of information I need to correct. Last year I won, actually. The proof to that is that David Kettles tomorrow is going to go public and is going to say and going to present to us on why he changed his mind and that he thinks prior PCI is the way forward. It took him a year of self-denial, but anyway, I'm glad I asked David. Anyway, the other thing is, me and David did not, this is the first time we look at this case, and we were told that it was 48 hours post chest pain, but it seems to be 27 hours. Doesn't matter, I'm always happy to be in a fight against David Kettles. It's gonna be bloody. There'll be no humor there. All set?
Actually, comment? Pico's got a good idea. We just got to quickly do a show of hands. And let's see how many would treat this patient conservatively. Well, this patient, conservatively or 27 hours out or PCI. How many would opt for conservative mode? Very few. How many would treat this, would open this vessel? So the vast majority, so actually the vast majority will do nothing.
Okay, it's time to start now. I have no conflict of interest present to this presentation, and I actually named it "It's Too Late." It's too late for PCI. Now, I'm just going to go through mainstream evidence-based cardiology. If you look at the ESC guidelines, and we are privileged to have one of the authors of the guidelines with us here, and it basically says, this time I will go close to the Siberian side. It's actually harmful. According to the guidelines, yes, it's actually harmful. It's actually harmful. It's a class 3B to have a delayed PCI of a totally lymphatic artery more than 24 hours after STEMI in stable patients. So the STEMI, it's stable, patient has no symptoms of angina and hemodynamically and electrically stable. If you do PCI for this patient, you're probably harming him or her. These are the ESC guidelines. So again?
American.
Oh, that's the, sorry, the ACC guidelines. Apologize. These are the ESC guidelines. And I think there's also agreement here. If routine PCI of a total occluded vessel more than 24 hours after symptom onset, again in a stable patient without evidence of ischemia, is actually harmful. I did not recommend it. This is mainstream evidence-based cardiology. There was a lot of confusion before because a number of small trials have showed conflicting results in this patient population. Some show that they do better when it comes to ejection fraction, some show that they have some more PCI complications, but these were small studies. And the largest randomized controlled prospective trial was the O trial, which changed the way we think about these latecomers who are stable. And since a lot of those who are here are not actually dementia cardiologists, I'm going to go very quickly over the occluded artery trial, which is for intervention for persisting occlusion after myocardial infarction. More than 2,000 patients, total occlusion, i.e., at TV flow 0 or 1. 1 means that it's faint filling of the vessel distally, it's incomplete and slow, of the infarct-ready artery. On day 3 to day 28 after the myocardial infarction, plus a high-risk criteria, which could be an EF less than 40% or approximate occlusion for major epicardial artery. So about half went to for routine PCI with stenting, and about the other half controls were optimal medical therapy alone. And we looked for a primary endpoint of composite primary endpoint of death, myocardial infarction, or heart failure. And this is actually the conclusion from the authors of the trial, which said PCI did not reduce the occurrence of death, reinfarction, or heart failure, and there was a trend towards excess reinfarction during 4 years follow-up in stable patients with total occlusion of the infarct artery if you do PCI starting from day 3 to day 28. And day 3 is a calendar day. So day the MI is day 1. And they start accruing patients from day 3. Doesn't mean 3 days post-MI, because the minimum time was 24 hours. After there was patients who were randomized at 24 hours, because if you come midnight at day 1, and then you had the angiogram early hours of day 3, that's maybe 24, 48 hours. So it's day 1 is the MI, day 3, calendar day, is recruitment. And in the, again, these were excluded from the old trial: heart failure, cardiac shock, serious disease, ongoing angina. If you look at the 5 years follow-up of all the composite points, there was no difference whether you do PCI or medical therapy in these latecomers. And if you look at the Kaplan-Meier curve for subgroup analysis, you can also see that once it comes to death, heart failure, they were the same, and there was a trend for more reinfarction, whether fatal or non-fatal, with the PCI group. It was not statistically different, significant, sorry, but there was a trend for more reinfarction in the PCI group. Many people, sometimes, when they're faced with the fact, they try to deny it. Just like the fact that David Kettles lost last time. So they said, okay, maybe because some of them, the stents were not patent, and hence you don't do well. If you look at the patent stents, then maybe these patients will find that subgroup analysis will find some evidence that they actually do better. So the TASC trial, which was actually the angiographic sub-study of the old trial, they did an angiogram as their protocol, another angiogram at 1 year. And they wanted to see if the stents were patent, did this patient do better? And they looked at primarily ejection fraction. And they did that for 87% of the population. They initially randomized. And they have 82%, or almost 83% patent infrared artery at 1 year, which is really good, compared to 25% medical group, which is auto-recapitalization of these vessels. So that was quite significant in terms of patency in the PCI group. No difference. I have to mince my beer at this time. So, look at the ejection fraction as a primary endpoint, and systolic and diastolic volumes, no difference. So the conclusion of the authors of this small trial, sub-study of the O trial, a PCI was stenting of a persistent included infrared artery in the subacute phase after MI effectively maintains long-term patency that has no effect on LV ejection fraction. And this is actually quite consistent with the mother trial, the O trial. Still, some people deny the facts. They're saying, okay, let's see those who came in very early, day 3 to day 7, maybe these early comers, or the late comers will do better. So, they looked at day 3 to day 7, and they compared medical therapy versus PCI in this subgroup analysis. And those who came in day 3 to day 7 fared as well or as badly as the overall cohort. So it doesn't matter if you were recruited day 3 or day 7 or day 14, it's the same. By the way, we said it's calendar days. So day 3, starting day 3, there were patients who were recruited 24 hours after the event. And you look here as a continuous parameter. These are days, overall cohort, and then you have PCI met in early versus overall cohort. And you can see the same results, even for those from 24 hours. 24 hours, 48 hours, 72 hours, they did as well or as bad as the overall cohort. No difference, starting from 24 hours. So mainstream cardiology is not making up facts and coming up with numbers that have no basis. Another denial. Let's look for viability. This time, if we can show there is viability, then maybe they'll benefit. So we have a subnuclear sub-study of the O trial. They do SPECT scanning, and they'll tell you, oh no, they have to use SPECT, it's old, they have to use SPECT, whatever. Okay, that's what we have. They looked at patients who had preserved viability versus non-preserved viability. You have viability, you have no viability, you have PCI, you have medical therapy, it's all the same. So actually, presence of viability, persistent viability in the infarct-related zone did not matter long term. They all did the same. And that was the result of the Oates nuke substudy. And this is conclusion of the authors. In the contemporary era of optimal medical therapy, PCI infrared artery compared to medical therapy alone does not impact LV remodeling irrespective of infarct zone viability. Basic science tells us that. We know 24 hours into the MI, myocardial cells almost completely dead. It's almost irreversible, complete damage to myocardial cells if they don't get blood for 24 hours or more. This slide of infarct zone, healthy zone. These are infarcted myocardial cells, the edematous, the well spaced because of edema, they're dead. These are healthy, these are dead. Given blood, 24 hours later, doesn't work. It's dead. And as time goes on, more granulocytes, then fibrous tissue, and a lot of granulation comes in 3 to 7 days later. But even at 24 hours, we see almost complete death of all myocardial tissues within the infarct zone. And this is not strange to PCI. And this is the famous graph here by Gersh. And we're privileged to have Bernie here. Even thrombolysis, we know there's a time when thrombolysis doesn't work. Because the benefit we derive from thrombolysis is offset by the fact that muscles no longer respond. Even you give them blood, or you perfuse them. I know there's some differences because of regarding patency and stuff. But for every procedure, whereby you're working on an organ that is dependent on time from its livelihood depends from time of occlusion, there always has to be a time limit whereby whatever you do to that organ, if you don't supply it with blood in a timely fashion, no matter what you do, not going to benefit the patient. And you might be actually subjecting that patient to a procedure that's unnecessary and might have inherent risks involved. So basic science tells us that. Thrombolysis tells the same story. This is a case from one of our labs in Khartoum. I thank the operator for sharing the case with us. The presentation, myocardial infarction, proximal LAD, a lot of clots. I'm sorry. Let me go over.
The video's not playing.
Come on. All right, it's playing now, isn't it?
Just
All
wait.
right. So you put a stent in first time, there's still no reflow. I don't want to go into details, it just shows that sometimes complication happens. It's quite rare, but it does happen. And when it happens for a procedure that has no benefit, that's the problem. And then here, on the, you can see a lot of thrombi in the left main. And these thrombi migrate down a big left circumflex. And now we see in this image the patient hands on the chest. I see temporary wire. And they also put a wire in the circle. I'm not sure if it's clear on this one. And then this is the last recorded video. This is the last recorded video from that angiogram, PCI, dead patient. the last recorded loop. In the late presumption, proximal LAD and a lot of clots. I don't know what details what went wrong. It just tells you that sometimes complications happen. The procedure has no better. My final slide. We, as cardiologists and doctors, we would like to help our patients. We have no limitations. The open artery theory is a beautiful myth. It's a beautiful myth. We know cardiac muscles undergo irreversible damage, almost complete reversible in 24 hours. We cannot subject our stable patients to procedure with risks for no good benefit. From 24 hours onwards, it's mostly damage control. Thank you very much.
Yes, once when I was part of a debate, someone said to me, made the accusation that I'm not always right, but I'm always sure. So I think Dave Kettles, I don't know how you agreed to accept this, Dave, but you're going to have to be at least sure.
Thanks so much, organisers. It's really a privilege to be here. I do have, is this mic? I'd love to have a roving mic if I could have one. Ah, thank you. Can I change to that? Thank you. I do have some disclosures to make with regards to this presentation. The first is that, of course, I will open the artery. I work in a fee-for-service environment. Academics have been telling us for decades that we, of course, it goes without saying. So that's my first disclosure. My second disclosure is that I watch far too many B-grade action movies with my 16-year-old son. And standing up on the stage here, in front of Gersh and Gershlik and Alexander and others, you know that part in the movie where the bad guy finds himself in a dark alley and momentarily he feels the hair on the back of his neck rising and he senses that there are 4 red dots dancing on his chest. That's what I feel like right now. It's the epitome of vulnerability. I think some of the red dots are probably from assassins directed from us St. Ahmed. But then after we speak about those experts, let me speak about Ahmed. Ahmed, you can't take one bad study, throw it in the trash where it belongs, and as it shatters into a myriad of sub-studies, begin to use them all as an independent slide. It's completely disingenuous, so let me give you the facts. I won't perform PCI. But I have to say to the organisers, it's a great question, thank you, because up to 40% of our patients with STEMI present beyond the optimal time for reperfusion. So let's talk about it. And PCI is neither completely benign, as we have had very nicely illustrated, nor very inexpensive. I would point out to you, though, that most cardiologists think they already know the answer. And we saw that with the show of hands at the beginning of the meeting. So let's first talk about the dogma. STEMI represents the occurrence of a time-dependent, complete myocardial necrosis after a total thrombotic occlusion. And that dogma is based on dogs, actually. It was shown very nicely to us earlier today, this article in Circulation in 1977. Beautiful, elegant studies which taught us so much. Look at that. Half of the myocardium that will be necrotic by 24 hours is already necrotic at 40 minutes. And of course, when we look at the early interventional studies in myocardial infarction, when we start treating, we see that the outcome of treatment confirms the dogma, doesn't it? Because the earlier you treat, the better the survival benefit that you get. But we are not dogs. Our arteries are not ligated, and streptokinase is not the same as primary PCI. And these are very important issues. Firstly, the physiology in the human heart after thrombotic coronary occlusion is low-flow ischemia, not no-flow ischemia. Secondly, there are numbers of factors that may increase residual blood flow in the human coronary occlusion and alter the time course of necrosis. Necrosis does not happen at the same rate in the 3rd, 4th, 5th, 6th, 10th, and 12th, and 24th hour as it does in the first hour. And we saw on the angiogram of this patient some left-to-left collateral flow from the diagonal branch to the left ventricular LAD apex. What do we see in humans? We see intermittent occlusion, we see collateral flow, we see incomplete occlusions. We understand that there is a concept of ischemic precondition. And it has been shown repeatedly by imaging studies that viable myocardium may persist for days after coronary occlusion. We know that 1/3 to 2/3 of patients have residual, silent or symptomatic ischemia after myocardial infarction. Myocardial infarction, complete vessel occlusion, is not a final event necessarily. Ask anybody who spent the last 10 years trying to learn how to open chronic total coronary occlusions. But there are a lot more buts. The restoration of antegrade flow may be beneficial independent of any effect on left ventricular function. Just because the muscle is dead and just because the ejection fraction doesn't get better, doesn't mean that the patient cannot benefit. Look at this study, 180 patients. Now, please note, followed up for 10 years. If there are going to be benefits, we're going to have to watch for a long time to see them, but we are patient. They matched these patients for age, sex, LV function, and they compared those who had antegrade perfusion in the infarct-related artery and who didn't. Remember, they had the same ejection fraction. The only difference was there flow into this dead muscle? And they looked at unstable angina, congestive heart failure, and death. And what did they find? Long-term morbidity and mortality is greatly increased in patients without antegrade flow in the infarct-related artery. It is bad to have a closed artery when your ventricle has been damaged. And then some randomized data, the BRAVE-2 study, 360 patients now, a little bit more contemporary. These patients got stents or conservative medical management. They were treated at 12 to 48 hours, but they had to be asymptomatic. So we took out the patients who you could arguably say would be most likely to benefit, and we looked at the rest. The primary endpoint was infarct size, measured on CT. Okay? Infarct size. The secondary endpoint was death, stroke, and recurrent MI at 30 days. What was the final result? Significant reduction in final LV infarct size. The secondary endpoint was numerically less in the interventional group, 4.4 versus 6.6%, not statistically significant, I acknowledge. Another small study, 212 patients, single vessel coronary disease mostly, and you may argue that a multi-vessel disease would benefit more, but nevertheless, 212 patients with Q-wave MI, 30% of them had LAD involvement, and they all had their first MI. PCI or medical therapy only between day 2 and day 15. The LVEF, again, 5% higher, statistically significant. And again, more patent arteries, but there was no difference in the clinical outcomes in a short follow-up. And then came the OATS study. Hold back your nausea. 2,166 patients randomized 3 to 28 days after symptoms. Apparently it wasn't 3 days, apparently it was something else, but that's what the book said anyway. Primary endpoint, death, myocardial reinfarction, class 4 heart failure. They followed them up, supposedly for 4 years. The event rates were statistically the same, but there was this trend that we saw earlier towards more reinfarction. I'll hopefully notice this full disclosure on my part of showing you the data as they truly are. They did look at which vessel was involved, ejection fraction, time delay, and they didn't find any interactions, as Ahmed showed us very nicely with treatment allocation. But there are some issues around the OATS statement. 50% of these patients had a right coronary occlusion. Need I remind you that in short-term follow-up, it's difficult to show a mortality difference in treating an ST elevation MI with primary PCI with a right coronary artery, especially a small one. Only 8% of these patients had contemporary treatment. Again, we were trying to find the group of patients most least likely to benefit. They had to have absolutely no flow in the infarct-related artery, and they had to be asymptomatic. But listen to this. These are massive centers doing primary PCI every single day. And they managed to enroll 2 patients per year in this study. And there is a very serious question whether this study represents contemporary practice. I think the other 100 or so patients that came through the cath lab in the same year were busy having their arteries opened. The length of follow-up only 50% of patients were followed up for 3 years. And despite the lack of efficacy in hard endpoints, listen to this. The patients treated with PCI significantly less likely to suffer angina, significantly, not a trend, at 4 months, 12 months, and 24 months. So this dead muscle was less likely to cause them pain going forward. And the question I ask you is, do oats occur in Africa? The answer is actually no, they don't really. You need temperate areas, you need 800 millimeters of rainfall at about 24 degrees to grow oats. The only place you can do it is in the Ethiopian highlands, and there's about 3,000 hectares of oats, you'll be glad to know, in Kenya. But 53,000 hectares out of 12.7 million hectares under oats worldwide. And I put it to you that even with the worst African ambulance services, you are very likely to arrive at your PCI center before 28 days. And I'd ask you this question. Does this really address our issue? Our issue is not the patient who arrives 14 days later. I mean, 2 weeks later, it's somebody else's problem. I'm not even on call anymore. I'm interested in the patient that comes to my cath lab and it's just past 12 hours or it's just past 24 hours on a big anteroseptal STEMI. Should I still open this? And I'll ask you one more thing. Do you really think that the pathophysiology of the infarct zone is the same at 24 hours as it is at a month? Is that the same pathophysiology? Could it possibly be? Let's at least aim for biological plausibility. I'll show you the Swissy 2 study, because this now looks at the group of patients who may well benefit. These patients just had an MI, and they got tested. In fact, they did a bicycle ergometer, and if the bicycle ergometer was positive with ST depression, that's the stuff all of you can do. What they did then was, they did imaging and confirmed that there was ischemia. And they randomized these patients. Can you believe those days, plain old balloon angioplasty or medical therapy, and they followed them up appropriately. 10 years. And what was the endpoint? MACE-free survival. And there's the graph for you. Now that's called a significant difference. A very significant difference. Dramatic reduction in events in the patients who were shown to have ischemia. So this late open artery hypothesis will just not die. Hardly surprising. Oh dear, what happened there? But it was postulated by Eugene Braunwald, none other than Eugene Braunwald. And the question that he asked with Dr. Kim way back, I think 93 was it? I can't remember. 93. Are there time-independent benefits of opening the infarct-related artery? And the answer is absolutely, there are many possibilities. There is an effect on LV remodeling. There is an effect that's been demonstrated in many studies. Reduction in end-systolic volumes, for example, is a uniform finding across these studies. So infarct expansion is attenuated when you open the artery. There's an improvement measurable in diastolic performance. There must be some effects on infarct healing if you've got blood into that area that is now getting fibroblasts and organization. There are electrophysiological effects. There could be enhanced electrical stability, and there is reperfusion of hibernating myocardium in the ischemic penumbra. There is also collateral blood supply to remote myocardium, which could be useful later on. So did oats end the debate? Absolutely not. Look at this. Chinese colleagues, 1,090 patients. Now we're getting to big numbers again, and this was published in 2015. It was not randomized. But they looked at patients treated by late PCI or patients who were treated medically after STEMI, median 10 days. LV remodeling was what they were looking at. There was a 65% reduction in risk for LV remodeling. Defined as left ventricular end diastolic volume increasing by 15% from baseline, and it was highly significant. Is my LAD, please open it. Ischemic cardiomyopathy is the endpoint we're trying to avoid. Adjusted MACE, significant benefit. Significant reduction in death, rehospitalization. So this was their conclusion. Late PCI strategy prevents LV remodeling, protects LV function, reduces MACE, all-cause death, and rehospitalization compared to conservative strategy. And here is a model. I'm not sure how well you can see it, and I don't have a pointer to show you, but essentially showing us that we're not getting right down to zero. there is, if you're going to revascularize with primary PCI, some residual viable myocardium, and that timeline extends out well after 48 hours. We know a little bit more though, because people are now digging into this question a little bit deeper. LV remodeling correlates with baseline viability. This is a small study, but a very elegant study. And what they did here was they did perfusion imaging in patients who had a closed infarct-related artery. And they had a look for viability, and they divided these patients into 3 categories: less than 20%, 20 to 50%, or more than 50% viability in the infarct zone late, more than 24 hours after STEMI. The very fact that they could divide those patients into those groups must remind you that these patients had viable myocardium. All of them had PCI, and then they had another perfusion scan at 6 months. And what did they find? Interestingly, what most interventional cardiologists would have intuitively thought was the case. The low viability patients were less likely to attain TIMI-3 flow after their PCI. They found 48% overall viable myocardium in the infarct zones of these patients. And at follow-up, again, left ventricular end-diastolic volume and end-systolic volume were reduced, and there was an improvement in the patients in LVEF if they had high or moderate residual viability. There's a direct correlation between the benefit you're going to find and the amount of viability that remains. That stands to reason, but you need very high-tech imaging to select those patients. And interestingly, those who had very reduced viability, that 1/3 group that had very, very little viability on sophisticated imaging, did they get any benefit? Well, they did have a reduced end-systolic volume, and they also had improved wall motion scores. So putting blood through dead muscle makes a difference. So their conclusion was, unless the patient has evidence of severely reduced viability, they can be offered revascularization with the intent of improving LV function. This is a more scientific approach to such patients than is the outright refusal of revascularization on the basis of clinical outcome data alone. And here are 10 studies which were put into a meta-analysis, and there's the result for death. The dark block on the left side of the unity line on the forest plot. And if you look at death or MI, it's still on the left side of the forest plot. And remember, many of these studies are all comers, and many of these studies have been chosen to select the patients with the lowest likelihood of benefit. So let me show you a case. Is it playing over there? Yep. Oh, it's playing there, not for me, sorry. This is a patient who arrived at my cath lab. Look at the collateral flow. And the LAD, proximal occlusion, looked almost exactly like this patient's angiogram, actually. My colleague is braver than I. I never do this. My young colleague feels that it's perfectly appropriate, so he pops a pigtail into the left ventricle and shows the apical infarct. He's braver than I am. Is there anybody in the audience who wouldn't have opened that vessel? Anybody? Oh, Ahmed, sorry. sorry. And look at the result. There you go. There's the LV function. Should have left that, just in case something went wrong? I don't think so. So pro-PCI, in this patient we have a big territory, we have a very good chance of viable myocardium. This procedure is usually simple, and it's getting easier, simpler, and lower likelihood of risk as every next generation of product comes into our hands. What about costs? PCI adds little cost compared to the cost of the initial angiogram, certainly in my context, because it's getting into the theatre that costs you the money. You may salvage myocardium, you will almost certainly reduce adverse LV remodeling, and there's a very high probability that you will reduce mortality long term. Against PCI, there are no huge randomized data sets to show benefits in hard endpoints. That's probably because nobody's prepared to randomize patients into such a study. Does context help us make the call? Can Africans afford 2 visits to the cath lab when you find out next week they've got post-infarction angina? Most of us have never heard about those names there. So they're not going to get that to check if they've got viability or not. And we would be following most cardiologists' usual practice if we just got on and opened the LAD, and almost certainly be helping the patient. How would we help them? Reduce LV dilatation and aneurysm formation, reduce post-infarction angina, reduce heart failure, improve ejection fraction, save him another visit to the cath lab to treat his CTO, probably reduce his risk of dying. Primum non nocere. It doesn't mean first do nothing. Thank you.
Very good, eh? So what are you going to say to that? We've got quick rebuttal, and then what I'd like to do is just get the panelists up here. Where's up there? While you're waiting, you did make an interesting point when you said that most people probably wouldn't randomize those patients. I must say, when I was involved in some of the initial discussions with the open artery trial, at Mayo we did not go into it. And that's because people wouldn't randomize them. We felt that we were rightly or wrongly.
I think, very sensational. Again, it's about sensation, it's not about facts. Most patients we see in the cath lab who come with late presentation MI, that LAD territory is gone. The EF at 35%. You don't have collaterals beautiful as this one. Are you convinced that you're going to open that artery and they're going to feel better? Or the LV is going to be better? No. It's going to happen. Also, Africans are poor. If there's a stent in there they don't need, that's extra money for them. And they're not going to benefit from it. I like the fact that you rely on a non-randomized trial from China. No, I meant China is just, don't misunderstand that. The other thing is a Swiss trial of 200 patients and an elegant trial of 68 patients and a Brave 2 trial that had no clinical endpoints, relied on infarct size and failed to show any other clinical endpoints. That's very sensational. Thank you.
I must say, David, you certainly chose some very obscure journals. I was wondering how you got that data.
Anti-Asian prejudice in this audience is palpable. Can I get my slides back, please? I've got more obscure stuff to show you. Okay, let's focus on what we do know, not what we'd like to believe. STEMI requires early, urgent revascularization by PCI or pharmacoinvasive therapy. We know that, and let's not let any of this speculation or debate detract from that message. Best outcomes in preservation of LV function is when you do that in the first hours after symptom onset, especially in the first 3 hours, especially in the first hour. But as time from onset of symptoms increases, benefits still accrue with revasc via various time-independent mechanisms. So many people have got post-infarction angina, or post-infarction ischemia that you're not aware about. If you're not going to look for it, maybe you can afford the luxury of bringing them back and doing the second PCR when you find it in about 50%. I would suggest, though, that if you don't have a SPECT or MR, maybe it's better just to open the artery while you're there. Benefits of late revascularization relate in part to the degree of residual viability in the infarct zone, but you need sophisticated equipment to find that. If you see some residual antegrade flow in a big vessel, that patient is probably more likely to benefit. Even in the absence of demonstrated ischemia, there's been many small studies in obscure journals that have shown you that LV remodeling is positively affected. Most of the other studies did not have sufficient length of follow-up. When might I personally opt for medical therapy? In a very small vascular territory, in a patient who's asymptomatic, where a high procedural risk is anticipated. The patient is frail, the patient's got renal impairment, the patient who's got an artery packed with clot where I don't think I'm going to get a good result. The patient has got a short life expectancy for any other reason, maybe just because they're in the 9th decade of life, and they're not going to live long enough to get the benefits of LV remodeling. Or, if I've had the luxury, perhaps if they've got very, very little viability on an imaging protocol, but I think that would be the least we could do. What should our focus be? Let's get access to reperfusion to as many patients as possible, get them into our labs as early as possible, and still treat them well, even when they arrive late. Perhaps we should sow the next oats in Africa, because I think we see more of these patients than anybody else. Thank you.
Thank you to both our presenters, and what I'd like to ask the panel is just, if we just start off with you, who would have treated this patient medically as opposed to PCR?
Thank you very much. My name is Dr. Gitola. I would like to begin by saying I work in a public national hospital where these are the kind of patients we receive all the time, and we do not have primary PCI in our public hospital, although we have cath lab. What I would say, I think from the discussion both are very good, and probably both of them are right in the sense that most of these patients are not, there are no protocols for these patients. There are not many patients who have been studied of this nature, and therefore when they come to us, many times we have to make really our own judgment in terms of what to do. And at the end of the day, really, the way I would look at it is, whatever you are going to choose, do no harm to the patient. Really, that is what all indicates. And therefore, whichever intervention that you choose, are you going to improve life? Are you going to prolong the life to these patients? And I do know most of the studies I've looked at, whether it's PCI or cabbage, prolonging life in most of these patients, we do know most of these interventions, they have not really prolonged life in most of our patients. So looking at the medical side, medical treatment, we do know most of the intervention that we do, including just patients who stop smoking cessation after many years, it has been shown to prolong life. So most of the medical aspect of management, they have done quite well in terms of prolonging life and improving care. So I think coming from that background, I would manage this patient medically, do the right thing, ensure you're not harming your patient, and as long as most of the other things are done, smoking cessation, starting to onboard, aspirin, I think those medical things they have done quite well.
Thank you. I think the one other thing we need to emphasize is whatever we do, many of these patients will have impaired LV function. And so anti-failure therapy, namely ACE inhibitors, beta blockers, and the aldosterone antagonists, are all evidence-based therapies that we need to not forget, even though the main argument is PCR versus none.
So I think it's a really important topic, and we haven't anywhere near got the answer yet. I think the problem with the data that we've got is either it's completely skewed by the retrospective nature of shunting people into groups who have PCI and those who don't, and a randomised trial which is deeply flawed because we allowed interventional cardiologists to make the decision on the table about what to do about lesions. David's last case was a perfect OAT case. but I bet you very, very few patients like that went into the study. And if they had gone in the study, we'd have had the answer that we want. We want the answer that says, open the artery, the patient will get better. Unfortunately, it's all about the left ventricular function. So once left ventricular function has gone, I'm doubtful that opening the artery with severe LV impairment is going to affect long-term outcome. It's going to improve LV function. But I think you have to judge it on a case-by-case basis. We do not have the randomised data to do that, so we have to look at left ventricular function before we put the patient on the
What would you have done with this patient?
I'd have opened the artery. But I'm an interventional cardiologist. That's why the study is flawed, because we ran the study.
So you know what they say, you know, to a man with a hammer, everything's a nail, and to an interventional cardiologist, everything needs opening. The other thing to say is that if David's PCIs are as long as his rebuttal, then there's no hope at all for a viable myocardium. So this is a great case, because it's right in the middle. And the sort of cases I won't open is when they come with no pain, 3 or more days later, with Q waves anteriorly. And I will do an LV angio, because the echo can be difficult to interpret, depending on who does it. And if the accepting high-donating myocardium and reperfusion injury, if on the LV angio that patient is akinetic, I don't open it. This case is different. I mean, there was some little bit of antegrade flow. The ECG is very problematic to me, that ST segment elevation, irrespective of the small Q waves. And I can't remember if the patient had ongoing symptoms or not. But this is a very different case, and I think on the balance of probability, that's the only thing one can ever say, I would open this, because I don't think I would do harm. And I think there may be some benefit. But if it's a Q waves anteriorly, with a occluded LAD, no trickle through, with on LV angio, an akinetic segment, and it's more than 3 days, I treat medically.
Dr. Johnson?
Well, I don't know what else I can say to say everything, but let me come from a different angle.
They're still shorter than David's rebuttal.
We get this case regularly, routinely, so this is something I deal with every day. And let me give an example. Somebody that came in 2 weeks ago. You know, like I said, in Nigeria, everybody goes to the church or mosque after chest pain. This gentleman was actually an imam preaching in a mosque, in a big mosque in Nigeria. He had his MI while he was preaching. They took him right to hospital. They did an ECG. He had an anterior wall MI. They gave him aspirin and Plavix, and then kept him, stabilized him for 3-4 days, and sent him to Lagos stable. So he came in, he was in pulmonary edema, we had to treat all that. Did his angiogram, LAD flush occluded, no collaterals from anywhere. Big circ, 3 OMs, all occluded. Just one AV groove circ. Right was non-dominant. I looked, I said, if I try to mess with this LAD, I'm going to take clot to that less. So I left him alone. I treated medically. Now, the question I have, which is very different from what we're talking about opening the artery, is ICD. The rule says wait 30, 40 days, reevaluate EF. His EF was 10. This man was not going to get another chance in a cath lab. My question was, who would put in an ICD then, as opposed to waiting a month or 2 and he's lost to follow-up and you can't put one in? I put an ICD in. But I'd like to get a response about that.
Well, let me comment on that, because I was also very surprised when the 2 ICD trials came out that they didn't show a benefit. And for a long time, I couldn't work out why, if the ICDs were so beneficial, why in 2 trials where they placed the ICD within 42 days, or 40 days, why was there no benefit? And eventually we did find an answer from 2 autopsy studies, and that is that in people who survive the first 6 months and then they die of arrhythmias, right, and heart failure. But in those first 40 days, there are 2 studies, 2 trials that had an autopsy arm, and it's clear that a large number of those patients were dying of reinfarction and also sudden asystole due to with an EF of 10%. So I think that the benefit of the ICD in those two trials was offset by the fact that they were dying of other causes, and including those you could reverse, like with revascularization. What I'm doing with these patients, I give them the best. Yeah.
So Bernie, we're all amongst friends here, so let's ask you, what would you recommend if a interventional colleague came and knocked on your door and said, Bernie, come look at this case, there's a trickle, this is the ECG, you're a non-interventionist, what would you do?
I'd open it. Now, I just want to ask you, all of you, actually, Jonathan, so you got a comment. Should we not be doing a stress test? I mean, the guy's 4 days out, you could do it. And look for ischemia, because then you really have a case.
I think it's sometimes even more basic. Look for viability as much as anything else. You can often see it in the echocardiogram rather than having complex MRIs done. If there's absolutely no viability on the echo, then I think you do need a stress test. But more often than not, you can see evidence of perfusion. You can do a contrast echocardiogram, simple, non-invasive. You can see there's perfusion in that territory. It's very, very rare that flush occlusion LED will not have some viability somewhere within the territory. But with an ejection fraction of 10%, it is difficult. I've had this argument with my electrophysiology colleagues who refuse to put an ICD in a young patient with an ejection fraction of 20% within the 6 weeks, because it's the same argument Bernie said, they die of other causes before their arrhythmia. And I think the argument is if that patient's then going on to have something else in addition, i.e. there's a step towards transplant or something along the lines at a young age, they should have it in early. They should have it in early. And the Live Fest is a sort of suboptimal treatment option, in my opinion.
Yeah, how we get around it, because you can't be reimbursed if you do it the first 40 days, is I just keep them on a monitor and I see a little run of VT and I say, okay. Yeah, they'll all have non-sustained VT if you look hard enough. Yeah. I think we should make the point, though, that, I mean, 3 of us have said we would open the artery, but we have to be honest. I mean, we don't know whether we're doing the patient in, whether we'll benefit the patient. We probably will not harm the patient, and there may be some benefit. But I think it's a good case. I mean, it's up in the air. Tom?
Yeah, just in defense of Ahmed, there's 2 things. For Dave's case particularly, which I think are important, is that
there was an excellent collateral from the right to the distal LAD. And that means, to me, that there's been a chronic lesion, proximal lesion in the LAD, which has generated that collateral. There was thrombus proximal to the lesion. There's always a risk, and I've done it before, of opening up that artery and embolizing down and obstructing the collateral. So I think there is an element of danger, and I think a comment about do the patient no harm is important.
One comment about, I think in regard to David Kettle's last slide, was say it's in Africa because these cases are more common here. I don't want to be, I'm not trying to be facetious at all, but I spent quite a lot of time with Pico at Kruitskeel, and they said, well, how would you treat a case like this at the Mayo Clinic? We don't see these patients. So this is a cause for concern, but a cause for encouragement, because really the bottom line is you have to develop the system so these events don't occur. Your patient who is treated and then sent to you 4 days later. So, you know, it's a problem, but it's a systems problem, because you won't see these patients if you treat them early. Yes, Dan?
Really, just one comment. Firstly, for this audience, I think it's really important that we stress that giving thrombolytic therapy in this time course is clearly contraindicated. I think that's one message. And then just to Tony's point about the ECG, Ahmed and I saw the ECG today for the first time, and I think we were both a little bit taken aback. For me, that ECG still looked very hyperacute. The T waves were still quite peaked and high and prominent. And if you're trying to justify that degree of ST segment on elevation in a patient who had a stuttering course, I think in this particular patient, we don't know, but it would have been for me one of the clues to say, hang on a second, this particular patient might have a benefit.
And it's too early for an aneurysm.
Exactly.
Too early for an aneurysm.
And the T waves, if it was an aneurysm with failed reperfusion, the T waves would have come down by now.
Yeah. I must say, I was one of the few that voted at the beginning to say that I wouldn't have done it. And what happens in our institution, because we can just speak about practice, is we do have a fixed budget. And one of the things that hasn't come up at all here is cost. Okay? So 3 or 4 days out. Now I agree the ECG here is controversial. 3 or 4 days out with stable Q waves, akinesia and echocardiogram, the patient actually wouldn't have gone for an angiogram. So we would have not had the oculostentotic reflex dilemma that you created about being an interventionist faced with the trickle. Okay? If we were going to do anything because of that, we would rather stress at that time and be driven by the results of stress or stress imaging. But we wouldn't routinely at 48, 72, 96 hours go. And I would beg to say that if we go back to the ACE inhibitor studies in this setting, the beta blocker studies in this setting that all showed remodeling benefit, survival benefit, et cetera, post-infarction, that they didn't have routine angiography, and they certainly didn't have PCI afterwards to influence those studies. And they become, class 1A treatment. So I think that would be the slight difference in our setting, where again we have a fixed budget, and for every patient that we take to the lab and open up, it usually means it's somebody who we might be able to benefit because we've got proper data on, but we don't have the option to do that. We wouldn't. Now, okay, like I said, the ECG here is slightly different. I said, if the patient presents 72 hours, completely stable, they've got deep Q waves, and there's no issue about what's happening with the ST segment, and you do an echocardiogram, they're akinetic, and even more so if the anterior wall looks thin, then in the absence of either symptoms or stress, they wouldn't have gone to a
Phil would agree with that, but this ECG is peculiar, and you don't have to do stress. I mean, on the one hand, you only have to look at viability, but of course there's the whole issue about hibernating stun myocardium. So it is difficult, and it is an algorithm that you have to work your way through. And sometimes, to be fair, although we all practice or believe that we practice evidence-based medicine, you just have to do what feels intuitively best for a particular patient.
Yeah, I mean, I think we've all, I guess, run into this also dilemma. I think one of the dilemmas here I wanted to also raise is really the issue of symptoms, because we've seen many patients who will say, I've had symptoms for 2 days, 48 hours, but it's not really clear. Is it really a 12-hour symptoms? Is it 2 hours then got better, then got worse?
Yeah.
So sometimes you're faced with this dilemma. Maybe it's actually 24 hours, but in reality the symptoms began 2 hours before. So the chance of maybe improving viability or improving myocardium is actually much higher because the symptoms began fairly recently, even though they're saying that it started 2 days ago. The second is, when we do these cases as an interventionist, well, maybe I know, but you know that you're probably going to be seeing a lot of thrombus, as was demonstrated. It sometimes is not a straightforward case. You're dealing with a lot of equipment, export catheter, serval stents. It may be a bifurcation lesion that you're thinking about. So as was mentioned earlier, and I won't say in support of Ahmed, but in support of the strategy that first do no harm, if I see that you're going to run into big problems and the chance of viability is very low, meaning QS waves, wall motion abnormalities that are not very severe on the echo, then I definitely would not be promoting that we use this strategy. But if they have some symptoms, maybe then I'd be thinking that this is sooner and there's some chance of viability.
One point about viability that we've always tried to make, all the studies like the STITCH trial viability were neutral. The problem is it's not viability yes or no. If you're going to look for viability, you have to look at SCAR, you have to look at remodeling, and you have to quantify viability, and that's complex and expensive and involves MRI and PET scanners and all of these things that are not practical and realistic here. But to simply say, there's a bit of viability there, it doesn't mean anything if the patient has a 7-centimeter ventricle with SCAR. It'll overpower viability. So viability is something I do believe in very strongly, but it's not realistic for many people to really identify it and quantify it.
Thank you.
Before we do a vote, do you have a comment, or is that related to the case? Because I just want to ask people to vote again.
Can I? Just a quick comment. I think Harun said a very important thing. In fact, I was going to echo that. The studies have demonstrated the time of chest pain is very difficult to interpret half the time. And specifically on this case, this was a very cleverly chosen case because that ECG had reciprocal changes. And also that ST elevation that Dr. Kath was talking about. And we have seen these patients many times. We go to the cath lab, we open the artery, the STs come down, that residual dilate goes, and you feel like you've done something. The patient who is 3 days out is a different patient from that patient, I believe, who is before the 3 days. And much as Ahmed said that the old studies took patients from some 24 hours, they were actually 72 hours out, maybe the majority of them, and didn't look at that patient coming in this way, stuttering, chest pain possibility, and actually have a case that we might relate to. So I think the chest pain assessment is a key issue. Now, just one question, really, maybe to the fraternity. In acute coronary syndromes, those patients who have a CTO seem to do worse than those who don't. So I don't know if keeping that artery open downstream for those patients who really fact to go on to develop further coronary disease, whether there's a benefit. I don't know what Bernie thinks about this.
Can I make one tiny little interventional comment on behalf of most people here who are responsible
interventionists? I think if this was a very dominant circumflex with a stump occlusion of the LAD, there is a possibility of doing harm. And nobody wants to get clot coming down it will be a lot of thrombus clot coming down the circumflex. So I think when you have the possibility of harm, I think that measures against intervention, whereas of course this case it was further down, less.
I think your point is a very good one. I mean, one benefit, at least potentially, of an open artery over time will be that you are providing collaterals to other vessels that the disease is progressive. And so I think that, I think that's a very good point.
Sorry, we chose this case specifically because it was the LAD, because it's an important artery, and probably in the long term we're looking at something that may recruit viable myocardium and so on. And I think each case has to be handled according to the territory supplied. I think somebody's made that point. And if the territory supplied is in a relatively small area and the general recruitment of benefit is going to be much smaller, then the decision is a little bit easier. But another thing that we face a lot is not the decision on the cath lab table, but the decision when the patient is phoning you, or when the doctor's phoning you in Kisumu, for instance, which is a flight, an air ambulance away, and they want to know, should we bring our relatives, spend $8,000 on a flight, get them across to you, do the angiogram, you find this occluded vessel, and there's some, often there's a lot of pressure to do something because, you've spent all this money coming here, and you found a stump, and it's in an important, or maybe it's a less important artery, but it's 1.5 or 2 days out. So these are some of the challenges that we have to face, and it really clouds the judgment. And in general, personally, my experience is not as exciting. I don't find that, 3 months later, the ventricle is pumping as well as Dave Kettles' patients was. I just find that we've opened the artery and we still see that scar, and it's thin now, and it's probably started to get an aneurysmal and maybe a bit of thrombus. And I wonder whether I've done very much benefit to the patient in the long term.
Patient's alive.
The patient's alive, yes.
Dave, did you have, was that the same patient name on the angiogram as the echo? But I think we also, the point is that you don't just do this to improve the ejection fraction. There may be other benefits from an open artery.
Yeah, I just have a quick question. What was the ECG like after? Do we have a post?
No, we didn't open that.
Oh, you didn't open it?
Yeah.
Did ECG change anyway?
No, we didn't do PCI.
Patient died.
So you agree with me?
So let's redo the vote. How many people would have treated this patient medically?
I'm confused.
The same ones who put their hand up before. How many would have opened this artery?
It's this side of the room.
So it's split, and basically the winner is those who wouldn't do anything. By far and away the majority. Any closing comments from the panel? I think it's been a great debate and a great topic that you chose, great case. Any further comments?
If it's my artery, please open it.
And try and avoid putting clot down. Thank you.
Very good. We're going to take a break for 20-25 minutes to reset the room.